Good morning, everyone. Welcome to Grand Rounds. I'm Noelle Spears, the Vice Chair for Education for the Department of Pediatrics. And today we are honored to have Rinad Beidas speak with us on implementation strategies to promote firearm safety as a suicide prevention strategy in pediatric care. As a reminder for those that are attending virtually, you can post your questions in the Q&A throughout the lecture, and then join us at the end if you want to stay on for an informal meet and greet with Dr. Beidas. For those here in person, the CME and MOC 2 codes are posted, and in virtual, they're posted in the chat. We are honored to have Dr. Rinad Beidas here with us today. She is the Department Chair and Ralph C.O. Paffenbarger Professor of Medical Social Sciences at Northwestern University Feinberg School of Medicine, which is my alma mater. She previously served as the founding director of the Penn Implementation Science Center at the Leonard Davis Institute at Penn until 2022. Dr. Beidas's research leverages insights from implementation science to make it easier for clinicians, leaders, and organizations to transform the quality and equity of care. As an internationally recognized scientist, Rinad has published over 250 peer-reviewed publications and has served as the PI of 11 NIH grants totaling approximately $31 million. Dr. Beidas deeply enjoys the meaning and joy that comes from collaborating with early career colleagues and watching them soar in whatever paths they choose. It is my honor to welcome Dr. Beidas today.
Thank you so much for that kind introduction, Dr. Spears. Can you all hear me okay? I know there's a little bit of challenges with the hearing, but I just want to make sure I sound all right. Can someone give me a thumbs up or a verbal yes? Great, thank you. Awesome. All right, one more thumbs up. Can you all see my slides? Awesome. Okay, I'm gonna go. Gotta love those features. So I'm so excited to be here with you all today. Wish I could be there in person, but I'm really looking forward to sharing a bit about some of our work with you all. Before I go any further, just want to share my disclosures. There have been a number of grants awarded to me and others that have supported the body of work that I'll be presenting on today. And then some disclosures that are outside of the work that I'll be talking about today, but in the spirit of full disclosure. So in the time that we have today, and I'm going to try to save some time at the end for questions and answers, but I have a lot of content planned. It's roughly organized into 4 chapters. I'll start by telling you a little bit about me and implementation science as a field, because having a good understanding of that will really inform the rest of the presentation. Then I'll tell you a little bit about the specific work I'll be talking about today related to firearm secure storage programs in pediatric primary care, some of the work that we've done over the past, I guess it's now 7 or 8 years in this space, and then some thoughts about the future. And I'd love if you put your questions into the Q&A, and I will try to keep eyes on that as I'm presenting if I can, because I really like to have interactiveness in presentations. So let me start with just a little bit about me. So I like to start all of my presentations with a positionality statement, and to share a little bit with you about my identities as a human, because they deeply shape my scientific perspective and the work that I do. I'm a Middle Eastern immigrant, trained as a clinical psychologist. I'm a community member. I'm a mom, and up until recently, I was a practicing pediatric psychologist. All of those identities really shape who I am and how I see the world. And the reason that I'm so excited about implementation science as a discipline, which I'll tell you more about in subsequent slides, is that I see it as a way to amplify and advocate for the voices in our communities towards the pursuit of social justice and population health for all. And then the last thing I want to say with regard to identities for this particular topic is I'm also a family member of somebody who died with a firearm, which is really what brought me to this work. So all of those things I think are really relevant for you as you think about the body of work I'll be presenting. I do want to take a slight detour and just kind of share with you all how I got here and how I came to be an implementation scientist. really focused, as Dr. Spear said, on trying to make it easier for clinicians and organizations to do the right thing. And really my path to implementation science emerged from a clinical observation that I had as somebody who was delivering cognitive behavioral therapy for pediatric anxiety that I just couldn't ignore, that really kept me up at night. So I'll give you the case example of, I'll call this person Jen. Jen was a 16-year-old female who came to the clinic that I was working in, which was a research-based clinic with severe and debilitating anxiety. And the really important part about this story is that Jen had sought out treatment in the community from a number of different providers before she made our way to our evidence-based clinic, where we were offering the gold standard, and she was really hopeless. At that point, she really didn't think therapy would work. Her parents were just taking her to another place. And I started to realize, as I saw this pattern happen over and over again, that kids weren't getting access to the care that they needed for pediatric anxiety. Just to share a little bit with you here, you can see an illustration that this particular patient made after treatment. After receiving an adequate dosage of cognitive behavioral therapy, she was able to do the things after care that she hoped to do and needed to do as a teenager. So as I saw that pattern happen over and over again, I came to the startling conclusion that young people were just not getting these evidence-based practices, and it completely changed the trajectory of my career. So I am a firm believer that all of the good scientific questions that we have come from either our own clinical observations or the observations of our colleagues or folks on the front line who are really seeing what types of questions we should be asking. Of course, this observation that I had as a clinician is not just idiosyncratic to my own experience, it's really a broader field-wide issue, and I think COVID has really brought this to light in a way that is very clear. This paper on the right by Paltiel and colleagues was a 2020 top 20 health affairs paper. And basically what's so interesting about that paper published before the emergency use authorization for the vaccine is that they demonstrated in a simulation that the implementation of the vaccine would actually have more of an impact on outcomes than the actual biological efficacy of the vaccine. And so I think it really calls to light how important the implementation is. And I think we've seen this play out now over the past 3 years. Last year, my colleagues Enola Proctor and Elvin Gang published an editorial in Science, which for us as implementation scientists really feels like implementation science has arrived, stating that COVID-19 has shown the world that knowing what to do does not ensure doing what we know. And so implementation science has become, a discipline and a method intended to really focus on this very matter. And I ask you as clinicians, as scientists, to think about the research to practice gaps that keep you up at night and how you might think about using implementation science to solve them. Just to level set and make sure we're all on the same page, I want to share my definition of implementation science, and then I'll share a little bit of a more scholarly one, and then do one more thing before I hop right into the topic for the day. So for me, when people ask me what I do outside of my academic circles, I talk about how implementation science is really about making sure that people are getting the things that work in the community and fundamentally moving the needle equitably in health. So if you think back to the example that I presented to you earlier, this fictional case example, you can see what I'm trying to do, what implementation science is trying to do, is to get the things that we know work out into the community faster for all. If you'd like a more scholarly definition, this comes from the National Cancer Institute. Implementation science is the scientific study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health to improve population health. That is ultimately the end goal. And there are lots of things, as we call them, that we might be trying to deploy in real-world settings, including procedures, programs, products, pills, you name it. But again, I ask you to think about what the things are in your life that you're trying to close the gap around. Something that has become very clear to me over the years as I've talked about implementation science with different audiences is that it's helpful to highlight the assumptions and foci of the field, which are slightly different from the traditional biomedical research paradigm. So the first thing that is probably the most important thing to keep in mind is that this work must be done in partnership with our communities. I'll say that just one more time to highlight and underscore how important this is. The work must be done in partnership with our communities. So the best type of implementation science work is done in embedded research models where a scientist might be alongside clinicians and organizational decision makers deciding what priorities to study and implement, not having an implementation scientist come to various health systems kind of saying, hey, you want to implement this? We really want to make sure that this is integrated as part of a broader vision for improving the quality of care. Second, the outcomes that we focus on, or our primary outcomes, are different from traditional studies. So you might be thinking about patient outcomes when you think about traditional biomedical research studies in the kind of applied clinical research space. And those are really important, but the focus in implementation science is really on clinician behavior within organizational constraints. And I'll show you more exactly what I mean by that as the talk goes on. Third, we don't see context as a nuisance. So any of the people in the room who've practiced in different clinics or teams knows that the context is different in various places that you work. And scientifically, we've often tried to kind of treat that as noise and put that to the side and statistically kind of control for that noise. But in implementation science, we're actually very interested in understanding that contextual variation and then deploying strategies to help us overcome those contextual factors. Fourth, that we usually want there to be an evidence-based thing that we're focusing on, particularly if you're applying for NIH funding and trying to do a large-scale implementation trial, because we don't want to spend the time thinking about scaling something if it's not actually going to help everybody. And then finally, the field has really matured. I've been doing this for about 17 years, and in those 17 years, so much has changed. We have a set of frameworks, methods, strategies, and outcomes that you can draw from and incorporate into your work that can really enhance our understanding of how to more quickly close the gap between research and practice. So I implore you to think about how to do that. And fortunately at Pitt, there's a great group led by Sherry Rogel, really focused on applying these methods to do that. So you're in a great situation. Not all schools have that kind of group. So said simply, and I try to say this a couple of different ways to make sure everyone's on the same page. This is a heuristic that my colleague Jeff Curran published 2 years ago. Think about the thing and the things that we do to help people do the thing. And I know that's super non-scientific language, but it really kind of distills it down to its core. The intervention or practice or innovation that you're trying to deploy in a new setting or in your setting is the thing. And you will hear me use that language. So I find it to be very helpful. Effectiveness research, which you may be very familiar with, looks at whether the thing works for patients. Implementation research looks at how best to help people and places do the thing. And our strategies are the interventions that we use are the things that we do to try to help people or places do the thing. And what we focus on in our outcomes are how much and how well people do that thing. And I'm going to give you one more heuristic framework before I conclude this section for the purpose of really driving this point home. I'm just going to quickly see. Oh, okay. I was just checking in the chat, making sure there wasn't a clarification question. So this is a heuristic developed with my colleague Megan Lane Fall at Penn and Jeff Curran, who I just described in the previous slide. And we developed this heuristic tool to help people identify where their work falls on what we call the implementation science subway line. So typically you might start by identifying some kind of gap that you're interested in, a care gap in the setting that you work in. And the first question you should ask yourself is there a thing or a practice of interest that exists that we could deploy to close this care gap? And I will be walking you through an entire research program that kind of maps onto this. So just try to pay attention. I know it's early in the morning because this is important. So the first question you might ask yourself is, has that thing shown efficacy? Meaning, has it been tested in tightly controlled randomized trials that prioritize internal validity over external validity? And just a side note, not everything goes through this step, but many things do. So if the answer to that is no, then you're on the red line of efficacy research. You can absolutely, and you must design for implementation. One of our biggest challenges is that many of our things have been designed in a vacuum, so they don't incorporate end user perspectives. And that is a big problem when we try to then take them into the settings in which they're intended to be used. So you can absolutely use implementation science principles from the very beginning to help you design your thing. But that is not kind of the bread and butter of what we do as implementation scientists. So let's say your thing has shown efficacy. The next set of questions you'll ask traditionally have been, has the thing shown effectiveness? Meaning, has it been tested in large-scale pragmatic trials where you're really focused on looking at whether the thing works with real-world clinicians in real-world settings with all patients? You know, that in itself is actually not implementation science. And this is a point where a lot of people are confused about this. We do have these hybrid trials where you can ask questions of both patient effectiveness and implementation, like what were the barriers and facilitators to implementation, or what were the set of strategies that you used, and some of those implementation outcomes that I described in the previous slide. That is our bread and butter, these hybrid effectiveness implementation trials, but just looking at the patient outcomes is not. And I'd encourage anyone doing this kind of work, I think there's a real opportunity for trialists who are doing pragmatic trials to incorporate implementation science right at that stage, because that is going to help us close that gap faster. Now, the bottom of this green line is firmly where we spend the majority of our time as implementation scientists. This includes mixed method studies to understand the context that we're trying to deploy a thing within, and then designing and testing our strategies in large-scale comparative effectiveness trials to see if we can help people and places do the thing. And the work that I'll be talking about today falls on that, the green line of the subway. So hopefully you'll be able to see a real live example of what this work looks like. So I'm closing up chapter 1 now. I personally believe that implementation science can allow us to move the needle and achieve the promise of scientific discovery and transform health and healthcare equitably. And that's what gets me up in the morning. Another way to think about this is to achieve impact at scale. And I'm going to now share with you an example of a research program that I think is highly relevant to pediatrics that spans the implementation science green subway to really bring this to life. All right, so now a little bit about why this work is important. Knowing that this is an audience of folks who are experts in pediatrics, I'm going to go through this quickly because I have a feeling you all know these statistics quite well. So firearms are now the leading cause of death in the United States for young people. So you can see here a graph. On the x-axis, we have years, and on the y-axis, we have deaths per 100,000 children and adolescents. This is CDC data, and you can see that firearm-related injury took over motor vehicle crashes somewhere around 2020, 2021. So this is a serious public health issue that I'm sure keeps all of you up at night as pediatrics experts. We also know in parallel that the rate of youth suicide has been increasing in the United States pretty steadily. From 2007 to 2016, the suicide rate increased 56%. Again, you can see here on the x-axis the date, and on the y-axis the deaths per 100,000 population age 10 to 19. And you can follow the red arrow of the blue line to see how suicide has been increasing. Importantly, firearms are among the most lethal suicide method in young people, particularly males, and they're responsible for about half of those deaths that you're seeing in that graph. Because firearms, a suicide attempt with a firearm usually results in death, this is a really important target for us as we think about suicide prevention efforts. 1 in 3 homes in the United States have firearms, and most homes with one firearm has multiple firearms. And from EPI data, we know that about 3 in 10 families store their guns unloaded and locked, with the ammunition stored separately, which is how the American Academy of Pediatrics and the National Shooting Sports Foundation and other leading organizations suggest that firearms be stored in homes with young people. So clearly there's room for improvement there in terms of secure storage. And there's been some simulation done work by Monato and colleagues showing that even a modest increase in secure firearm storage in the United States could prevent up to 32% of firearms deaths in use, including suicide. So that really suggests this is an important modifiable target to reduce suicide, and also unintentional injury. One important point that I just want to highlight for everybody is that in the wake of COVID-19 and the civil unrest that followed, 5.4 million people became new gun owners, meaning they had never owned a gun before. And so what that means is now there are more than 5 million children who live in homes with firearms that did not previously have firearms. And many of those firearms were acquired during a time when attending firearm safety courses might have been difficult in the early days of COVID. And so this suggests even more the salience of this work. So now that I've set the stage for why this is important, I'd like to share a little bit with you about the body of work that we've done since about 2016 in this space. So I shared with you earlier that I am a family member of somebody who died by suicide with a firearm, and that coincided with the birth of our first child. So when that happened, our son was 6 weeks old. And I remember, in the first year of a child's life that you go to the pediatrician all the time because there's lots of child visits. And I had this kind of light bulb moment as I was taking my son to his pediatrician, that the doctor was asking me all kinds of safety questions about how my child slept and the car seat and the fire alarm in the house, but never asked me a question about firearms secure storage. And so that was kind of my aha light bulb moment. And I asked myself, and our research team asked, where could we reach the most young people if we really wanted to intervene to increase secure firearm storage as a universal suicide prevention strategy? And I also shared with you, I'm a psychologist. So, my first inclination is always to think about behavioral health because that's my training and that's where, I practice clinically. But if you look at the literature, we know that only about a third of young people visit behavioral health care in the year prior to a suicide attempt or death, whereas the majority are going to be visiting primary care. And so we really started to think about pediatric primary care as a critical place in which to introduce this idea. And of course, not the only place, but as a really good place to start. There are lots of other places that are important too, including schools and specialty care. And I know that pediatric primary care providers have so much on their plate and they're asked to do so much in the context of a small visit. However, we felt like this was a good place for us to start doing collaborative work. And if you go to the literature, I'm sure you're all familiar with this, there is an evidence-based practice for pediatric primary care around secure firearm storage. It's called the safety check. So Sherry Barkin and colleagues at Vanderbilt in 2008 did a large pragmatic trial in hundreds of practices across the United States, testing the effectiveness of the safety check, which actually is broader than just secure firearm storage, and focused on parent storage behavior subsequent to receiving the program. And I'm going to really drill down onto the firearm component of the safety check because that's what we have focused on in our work because of the focus on suicide prevention. And there's really three core ingredients to the safety check related to firearm storage. One is screening for firearms in the home. The second is having a brief conversation with a parent about the importance of secure firearm storage. And the third, and probably the most important active ingredient, is offering a free cable lock at the point of care. So keep those three components in mind as we move forward. So the original safety check was really focused on unintentional injury, not suicide prevention, and it was meant for kids aged 2 to 11, so parents who had kids that age, and it was really bundled with other violence prevention approaches. But if you look at the data, what you see is that parents randomized to receiving the safety check reported double the odds of secure storage behavior following the intervention compared to parents in the control condition who actually showed poor secure storage behavior following in the subsequent time period. So this is really important, and this is something that has been endorsed by the American Academy of Pediatrics, yet we know that these things likely are not happening within the context of care delivery. So we then spent a good amount of time, and I'll be happy to talk in the Q&A about why I think it took this amount of time to thoughtfully implement an adapted version of the safety check in a partnered fashion with health systems. And so I just want to bring you back to that subway line that I talked about earlier in the presentation. This work that I'll be talking about, these 4 steps really map onto the subway line really nicely. So the first thing we wanted to do is a clinician survey, really to understand current perspectives and acceptability around those 3 program components, and actually to get a sense of use. Because there was a sense when we talked to clinicians in the field that folks weren't doing these practices that had been recommended by the AAP, but we didn't have good data to suggest whether or not that was happening. So the first thing we wanted to do is just demonstrate the gap and understand clinicians' attitudes towards using those particular program components. We then followed that up with a set of in-depth interviews with lots of different perspectives on basically trying to represent any perspective of an individual who might be impacted by the deployment of such a program. And what came out of that was that we needed to do some program adaptation, particularly given that some time had passed and this was really focused on suicide prevention. And then finally culminating with a large-scale trial to test different ways to help people or places do the thing, which in this case is the adapted version of the safety check. So I'm going to walk you through each of those stages to help you understand what we learned and how the work built to what we're doing now. So I mentioned early on when I was talking about the foci and assumptions of our field that partnership is really foundational to the work. And I just want to call that out. So the only reason we were able to do this work at scale is because the NIMH has funded a mental health research network, which is a consortium of 14 healthcare systems who collect similar data and are willing to participate in research. And so the work that I'll be sharing with you represents partnered work with Henry Ford Health in Michigan, Kaiser, Colorado, and Baylor, Scott and White. And those were all participating health systems in the mental health research network. So the first step I described was that we did a survey so that we could understand attitudes and use of the 3 program components. To answer the question, what clinicians report with regard to those factors. So, and this was funded through an R21 from the National Institute of Mental Health. We sent out a survey within 2 large health systems to about 100 clinics, and most of them responded, which was great. Most of them we had 1 survey respondent from. And we had 103 physicians who responded to the survey, which was about 50% of the physicians employed within the clinics and those health systems delivering pediatric primary care. They were 60% female, about 44 years of age, and about a third had a firearm in the home, which reflects national distribution of firearm ownership. And this was a very simple survey. We asked 2 questions a couple of different ways. First, we asked whether or not each component of the safety check, so screening, brief conversation, and giving out cable locks would be an acceptable suicide prevention strategy in their practice. That was to get at attitudes. And then we asked them how often they did that thing. And we asked the question 2 different ways. Once for all kids, so a universal approach, and then once for kids that they perceived as high risk. And we did not define what high risk meant because at the point of care, that would be a clinical decision made by that pediatrician. And so what you see here are the results of that survey. So I just want to orient you to the graph. On the x-axis, you can see those 3 program components that I've been talking about: screening for firearms, counseling, and giving a cable lock. And on the y-axis, you can see the Likert rating from 1 to 6 around the acceptability of that program component, with 6 being the highest acceptability score. And in purple, you can see clinicians' attitudes towards doing this for all kids, or a universal approach. And in gray, you can see their attitudes towards doing this for high-risk use in an indicated fashion. And my takeaway from this graph is that overall, clinicians found these 3 components to be mostly acceptable, that they found it more acceptable for high-risk use. You can see that the ratings are higher in the gray bars. And what I will say is, in general, the rating for giving out cable locks was a little bit lower statistically than screening and counseling. And I can tell you a little bit more about why that might be the case when we dig into the qualitative data. But in general, you see the ratings at around 4 or above, which to me suggests that it's acceptable. Is it the most acceptable thing? Maybe not, but definitely not very low ratings here. When we asked them to report on how they use these program components, they reported rarely using them most of the time or always. So again, you see on the x-axis, the program components, on the y-axis, the percentage of clinicians who endorse using these components most of the time or always. You see that it's quite low. And I think we probably would all agree that this is lower than we'd like to see, especially given the current state of affairs with firearm injury being the leading cause of death in the American Academy of Pediatrics recommendations. So that's the quantitative data, the simple survey to understand attitudes towards the program components and current use. And that was conducted now probably in 2017. So it's been some time. So I'd be interested to see how those answers have changed as this has become more and more of a pressing public health issue. So the next set of work that we did was really focused on trying to dig deep using qualitative methods and interviews to assess perspectives on how best to implement the program. And this was work led by my colleague at Penn, Courtney Benjamin Wolk, published in JAMA Network Open. So what we did was conduct 70 semi-structured interviews with 9 groups. And these were groups that we thought would be potentially affected by the implementation of this program. And what you'll see is the names of the groups and then parentheses for 3 of those groups. That represents firearm ownership because we specifically asked about that in those groups. And we were trying to oversample for parents who are firearm owners, given that this would be particularly salient for them. One thing that I'd like to call out is that initially we did not think to talk with firearm experts or firearm rights advocates, but as we started doing our interviews, we realized the critical importance of talking to that group. And I'm actually going to present some data from that group specifically, which has really informed how we've thought about the deployment of this program. So just want to call out that as scientists, we have to approach this work with humility. And as we're going, sometimes we learn things that really suggest that we need to take a different or an additional approach. And that did happen in this study. So the groups that we were interested in talking to were parents, physicians and nurses and nurse practitioners, leaders of the health systems that we were working with, including primary care, behavioral health and quality improvement, third-party payers, and then leaders of national bodies such as the American Academy of Pediatrics and firearm experts. And we used a leading framework from implementation science called the Consolidated Framework for Implementation Research, which is broadly 5-domain ecological framework to help you think through which levels you might need to be thinking through when you're trying to do an implementation. So you want to think about the intervention or the program itself, so the safety check. You want to think about the inner setting, which is where you might be deploying this intervention, the clinics or the health system, the individuals involved, which includes the clinicians, the outer setting, which is the broader sociopolitical context in which you might be implementing, and then the process of implementation. And we use this framework to guide the questions that we asked these individuals that each represented these groups. So high level, because I'm going over a lot of information in a small period of time, I'm going to share with you some of our findings by each of those 5 domains. So the first thing I'll start with is that outer setting or that broader sociopolitical context. So I think we're all aware that in the United States, firearm culture is really important, and it can be a politically divisive topic that can raise concerns around Second Amendment rights and illegal ownership. And so that's something that we really need to be thinking about as we implement, both from a scientific perspective and practically. As a clinician, you might ask yourself, what's the firearm culture like in the particular community that I practice in? This is a quote from a behavioral health leader whose perception was that we were coming into a culture trying to do a very reasonable urban intervention on a mostly rural population that's politically very charged around gun rights. So really knowing your community and your context and how you might adapt your approach to meet those needs. Interestingly, a number of folks that we talked to while we were doing these interviews shared that recent high-profile gun-related incidents actually made it easier for clinicians to initiate these questions. So when we were doing these interviews that had just followed the shootings in Las Vegas, and a number of folks said that really was those types of incidents made it easier for them to talk about this with parents because it was, salient. With regard to the inner setting, those are the factors related to the environment in which one might be implementing, such as the clinic or the health system. We heard about the need for system buy-in and alignment with priorities. So this leader of a primary care practice said, I think the health system's really good about standardizing things and rolling it out, but at the top level, if that level is not sold on it, then nothing will happen. And that goes back to the comment I made earlier about the importance of partnered work, and that whatever you're implementing actually needs to be a priority for the systems that you're working with. Otherwise, it's unlikely that you'll be successful. We heard a lot about the importance of the clinicians and how they might deliver the program. So variable knowledge about how to talk about firearms, as well as self-efficacy and comfort, and a real need for a non-judgmental stance. A number of parents noted that they felt judged when they talked to their clinicians about firearm ownership, and that it was very important that they not feel like politics entered the exam room. We asked about who would deliver each component of the program, screening, counseling, and the firearm locks. We heard that nurses and MAs could deliver the screening and the firearm lock portion, but that there was a sense that the clinician, whether that's a physician or a nurse practitioner, should do the discussion around secure storage. And then we also heard some really important insights relating to the program itself. So if you remember, the quantitative data suggested that there was good acceptability for the different program components with a slight lower acceptability for the locks. And I think this really helps illuminate that. So the qual data triangulated this idea that there's high acceptability and feasibility around screening and counseling. Related to the locks, there were some concerns about how a system would pay for that, where they would store the locks, how they could distribute them, as well as a minority of individuals raised concerns about potential liability if a lock wasn't used correctly. In this aspect of the work, we heard a fair amount about the need to adapt the safety check for the target population, and given that we were now doing this in this broader context. Other things we heard, which will be no surprise to you all in the pediatric space, is time emerged as a major barrier. So it was clearly stated that this program needed to take less than a minute, and it needed to be something that we could do quickly, and it needed to be integrated into the electronic health record in some way to help make it easier for clinicians to deliver the program. This leader of a primary care practice said, if you really want things done, you put it there, the electronic health record, and then it's easy to track whether or not they did it. And also a real sense that it needed to be integrated into the workflow and not be something extra. Now, I mentioned earlier in the talk that we learned really important insights from the firearm experts that we spoke with. We spoke to 12, and again, these were master firearm safety course instructors nationally, as well as folks who identified as firearm rights advocates. This was work led by my colleague, Sherry Yeager-Hyman. And what we learned was really important. And this was something we did not hear in the earlier work, which was that there's a real concern about the screening component of the program, because there was a sense that people were worried that if this was documented in the electronic health record, that at some point that could be extracted and people could be put into a federal registry of firearm owners. And so this theme emerged very clearly. We also heard about a lack of trust, and that some folks felt like the public health platform around firearm injury and mortality might be a disguise for firearm control, and that partnership with the firearm safety community is going to be really important because they're more credible messengers, and they understand the context in a way that healthcare professionals might not unless they're part of that firearm community. So these were really important things that very much informed how we thought about the program, and primarily the adaptation. We actually have taken out the screening component. because this is something that all people should hear. This is a universal approach. And given that 1 in 3 homes have firearms, it's very likely that a child is going to be in a home with a firearm. And so it's important to have a conversation with that parent, irrespective of their ownership. And that then allows them to decide and give them agency about whether or not they share any details about their own ownership. It's not needed. It's just a general conversation about storage and offering of free locks. And I can tell you even more about how we tried to make it easier, kind of like a condoms in baskets in a bathroom approach, so that people didn't feel like they were being targeted for being firearm owners. So I mentioned that we needed to do some programming, and I've already dug into that a little bit. This is work led by my colleagues, Molly Davis and Katie Hoskins, and you can read all about it in the citations that I've shared below. But essentially, we used an established adaptation framework. It's called ADAPTED. It's often used in the HIV literature. That's where it originated. And we use that to iteratively adapt the safety check so that we could deploy it in a way that would be effective in our work. So to do that, we took all that qualitative feedback that I just described to you from the interviews. We made changes like the one I just described, like getting rid of the screening step. We then presented the adapted program to 9 suicide and firearm safety experts. And we went to the field and we crowdsourced the name and the logo for the program, and got feedback from almost 600 parents nationally using MTurk. We then incorporated the feedback from the 9 suicide and firearm safety experts and the name and logo, and we created the adapted program, and then got quantitative acceptability and appropriate ratings on this adapted program from a new sample of 106 parents. So I don't want to belabor the details here, other than to say we spent a lot of time trying to ensure that this program would be acceptable and appropriate from the perspective of both firearm owning and non-firearm owning parents. And that was really important, I think, and helped us a lot as we've launched our trial and are continuing this work. So the adapted safety check, the firearm component, is now called S.A.F.E Firearm, Suicide and Accident Prevention Through Family Education, and this is the name that parents came up with. And it only includes that brief conversation about secure storage and offering of cable locks. And on the right here, you can see those new 106 parents that I described at the end of the adaptive process, their acceptability and appropriateness ratings. And you can see on a 1 to 5 scale that it was quite high across the board. So now I'll share, it's actually step 4, the final step, and tell you a little bit about the active trial that we have ongoing that's funded through an NIMH R01. So basically, as part of the R21, so this is still before the R01, we took all that input from all the work that I just presented, and we did this process called implementation mapping. And implementation mapping is basically a way to derive the set of implementation strategies that you need to deploy that particular thing within that new context. And just as a reminder, a lot of the things that we heard in the process of collecting information from partners was that the adapted intervention needed to be short, that it needed to attend to issues related to firearm culture, and that the strategies that we took to implement this and needed to integrate the program into the workflow, have leadership endorsement, and ensure that all clinicians have self-efficacy to have these conversations. So what we did is, and these are some of my colleagues who assisted with this process, is we took all this information and we developed an implementation research logic model, which would help guide the trial to come. And what you can see here is that we have the barriers and the facilitators that we heard about in the interviews related to time and self-efficacy, firearm culture, et cetera. And then we picked implementation strategies, which are the things that we do to help people in places do the things that addressed those barriers and facilitators. And then we designed our outcomes. Our implementation outcomes are really around reach, the number of parents of kids who receive the program over the number eligible, and then also some effectiveness outcomes related to parent storage behavior and firearm injury and death. So this can help you think about how we ended up coming to the trial that we are doing now that's wrapping up in March. The study protocol for the trial is published if you're interested in reading more about it, and it's in partnership with Kaiser Colorado and Henry Ford Health. And the main thing that we hope to answer in this trial is whether or not the less costly and scalable electronic health record-based nudge that we deployed to implement this program is enough. Or if we need more intensive and expensive facilitation, which I'll tell you a little bit more about in a moment, to overcome implementation barriers in the case of this particularly sensitive intervention. So we're doing something called a hybrid type 3. So if you think about that subway, it's that line where I said we have those hybrid designs. A type 3 just means that we're really focused on the implementation outcomes. And that's what we powered on versus the effectiveness outcomes. And we're working with 30 clinics, about 150 clinicians, and this is about 40,000 well child visits. So half of our clinics are just getting the nudge, and I'm actually going to show you what the nudge looks like in a moment. But that's basically, we changed the well child visit template to include a prompt in the kind of safety section about whether or not the clinician had the conversation and offered a cable lock. So half the clinics are just getting that, and the other half of the clinics are getting that plus facilitation, which is basically support to the clinics around the deployment of the innovation, answering questions, providing audit and feedback, and that's been delivered by external facilitators who don't work in the clinics and those health systems, but people who are employed by those health systems. And we're primarily interested in reach, so how many of the parents receive the program over the number of parents eligible, but we're also doing some primary data collection and doing some follow-up phone calls with parents to understand their perspective of whether or not the clinician spoke with them and offered them a lock, as well as parent storage behavior. And we're also looking at the mechanism through which our strategies work, which is hypothesized to be clinic level adaptive reserve, which is basically how well the clinic can absorb the new practice. Just to give you a flavor for what things look like, we have a handout that we give parents, as well as the free firearm cable lock. You can see here our little logo is on there, and the EHR documentation is on the right. So actually, it looks a little bit different at each health system because we wanted to integrate it into the workflow that they had around clinician decision support. So at Henry Ford, you know, it's a yes/no question because that's how their questions look. And at Kaiser, it's a list of options. And so that's the nudge. And then facilitation is as I described it earlier. I just want to note that we have had a colleague, Katie Hoskins, who has led work to help us think about equitable implementation. You may have noticed when I defined implementation, I noted for all and equity as being a really important part of implementation science. And that's always been implicitly baked into how I think about it. But more recently, the field has really moved towards being much more explicit about how we think about equitable implementation, because you could imagine that an implementation project at the scale that I just described could either create inequities or reify existing ones. And so she's denoted this 5-step process that is based on recommendations from the field that really operationalize how we thought about it for this trial. And importantly, in the case of this particular program, a priori, and in talking with our partners, our clinician partners, there was some concern that the program wouldn't be delivered to medically complex youth because of the length of time needed for a well child visit. We were also concerned with increasing inequities in suicide deaths in Black or African American young people. And so essentially, based on our engaging with partners and reviewing the literature, we decided to do a pilot to study signals of inequities so that we could have a plan if we saw inequities that emerged. We also looked post hoc in the pilot and found that clinicians were less likely to deliver the program to parents of girls compared to boys. Katie developed a way of thinking about giving feedback to clinicians around the importance of equitable implementation. This was just a pilot, and it wasn't the focus of the trial. And so in future work, we're really interested in thinking about how to build equity-focused facilitation into the work that we do with clinics. So I have the hours up, and I want to just wrap us up, talk a little bit about implications and future directions. This is a really important point that I want to highlight for you all. We all have a shared mission to keep young people safe. This work is about firearm safety, and it is not about firearm control. I believe personally that taking a harm reduction approach, as we've done with other public health efforts, will be the most effective strategy here. And we've written a little bit about this, but we really need to think about how we can partner with families to ensure that they are taking the approach that they're most comfortable with, that also will result in the most safe home environment for young people. Second, partnership is critical, and it's really important to hear the voice of all partners, not just the ones of those who are typically represented in the public health discourse. And so the firearm experts that we spoke to deeply shaped how we took this program to scale. And I think that it was incredibly valuable, and I'm so grateful to them for their expertise and feedback. What I've shared with you today is ubiquitous, and these methods can be used across diseases, evidence-based practices, and settings. So I personally do this work in HIV, cancer, cardiovascular disease, mental health. We have a trial on de-implementation of pulse ox with young people hospitalized with bronchiolitis in partnership with Chris Bonafide at CHOP. We do this work in lots of settings, including primary care, acute care, specialty clinics, and schools. And so even if what I presented to you today isn't necessarily an area of interest, all the methods that I used in that process that I laid out is highly relevant across the board. I want to just bring us back to the mission statement that I shared with you at the beginning of this talk, which is that I believe that implementation science can allow us to move the needle, achieve the promise of scientific discovery, and transform health and healthcare equitably or achieve impact at scale. We spend billions of dollars on discovery, and we spend a very, very small amount on implementation. And if we want those discoveries to actually reach everybody faster, we must focus on implementation. Finally, the list of people who have contributed to this work is incredibly long. I'm presenting it today on behalf of our broader team. So I'd like to thank them all. Without them, this wouldn't be possible, as well as my family and the funding and the organizations that have supported this work. And I will close now and open it up to questions. My email's below, but if you Google me, you'll be easy to find me, and my Twitter is also listed below.